So today I want to try to share with you from the literature how adding a mobility assessment can be valuable to a comprehensive geriatric assessment, how it improves what we do already in a comprehensive geriatric assessment. Then I'm going to try to offer some practical advice on how and when to conduct a mobility assessment, sharing a little bit about what we have been doing in our clinical practice, but also relying on the literature and what we do and do not know about that. And then I will share 3 ways in which I think we can translate the mobility assessment results right into our management plans, how that can shape our management plans. And then I'm going to actually end with my research related work, which is sharing how we might think about assessing mobility in the future using some technology. Here are my disclosures. So first, the value of the mobility assessment. To frame this first part, I want you all to think about your patients who are 80 years old, or pick an age, 85 or 75. I think you would probably all agree with me that there is no 80-year-old that looks and acts and responds the same. Everybody is different. In fact, health variability is a hallmark of older adulthood. And so with that in mind, let's talk about the mobility assessments. So first of all, there are a ton of evidence-based mobility tools. I'm just showing you a few here. Some single measures. We have usual walk of various duration. We have rapid walk assessments. We have endurance walks of various lengths. And then I've also included some that are not just walking, but measuring aspects of mobility that are important to maintaining mobility. So activity, strength, upper and lower strength, various kinds of balance, static and dynamic balance. And this is just a small example of the measures that we have in the literature. And then people have taken these various measures and pull them together in different tools. So we have a number of combination tools as well, and I'm only listing again a few of them here. The short physical performance battery, which combines a chair stand, a 8-foot usual walk, and a static balance. The frailty phenotype that includes a 15-foot walk, grip strength activity, the timed up and go, which I'm sure you've all heard of, and various others. And each of these combination tools has their own set of literature behind it. So it can be a little bit overwhelming at times to weed through the mobility literature and kind of get a grasp of what's going on, since everyone sort of refers to different scales and has different scales that they use. But we have no shortage of evidence-based mobility measures, that's for sure. So for the first value I'm going to suggest here, offer here, that the mobility assessment can add is it adds just practical physical exam information about the musculoskeletal and neurologic system. So as you're watching somebody walk, you're not just measuring their time, you're also looking to see if they sway while they walk. Do they need to hold on to the wall? Do they have arm swing, appropriate arm swing? Are their strides the same length? Are they dragging a foot? You're looking at other aspects of their gait characteristics as they're walking. You're also assessing things like their walking device use. Do they even have a device? Is the device that they have enough support? Is it being properly used? And you can also start to localize where their areas of muscle weakness are. Is it their upper extremity? Are they struggling to stand up from a chair? Do they have a weak hip flexors? Are they having difficulty turning around? Do they have core balance muscle issues? So very practical information that you can gather by doing a mobility assessment that we can address directly in our assessment plan. So that's the first value. The second value is, as we pick up impaired walking speed, we aren't really just detecting impaired mobility. We're actually picking up impaired physiology. So slow gait speed can also reflect impairments in the energetic balance of the body. People can have a catabolic state where they have perhaps chronic inflammation that's requiring a lot of energy to maintain their homeostasis. They might have a physical disability that's leading to impaired mechanics of walking that's making their walking an inefficient energy expenditure. We may be reflecting aging cellular senescence in the muscle cells themselves. We might also be picking up changes in the muscle quantity or muscle quality by seeing an impaired gait. We might also therefore see actual muscle weakness or impaired functional capacity. We might also be reflecting some changes in the neuroendocrine regulation, such that we have poor nutritional responses or stimuli leading to some chronic undernutrition, even micronutrient deficiencies at some level. We might just be reflecting a lower activity level, either electively low activity or in response to sarcopenia. So measuring mobility is really a direct reflection of impaired physiology. And I think this is a separate value to consider in the comprehensive assessment and how we translate that into our management plans and think about mobility. So a third value that's related to this is, while we measure mobility in the clinical setting and find impairment, while it is reflecting this underlying kind of molecular, genetic, physiologic impairment, it's also often predictive of these poor outcomes and often precedes the poor outcomes. So we can detect mobility impairments before someone has a fall if we do it regularly, for example. So there's a value here by doing a mobility assessment, by preventing these events that could lead to loss of independence. So I think this third value is just focusing on being able to prevent those events from occurring by picking up the mobility impairments early. Yet another value, which is very similar to the former, but I want to bring it up separately because I think it actually adds a unique aspect to the mobility assessment. When we do use an evidence-based tool as our mobility assessment in our clinical geriatrics clinics, we actually have a quantifiable, measurable, numeric value that can assign risk for particular clinical outcomes, like procedural morbidity, mortality, like rehospitalization. And that numerical value, the quantification we can get from the scale itself and the performance of the patient, actually helps us assess risk and communicate that risk to our referring colleagues, surgeons, to patients' families, and help improve decision-making around that risk. Here's a couple of examples of the studies that have demonstrated various mobility measures improve risk prediction in the setting of risk stratification. So this was a study done by Dr. Macquarie, in which they assessed about 600, not quite 600, older adults who were in the pre-op clinic headed to an elective general surgery, major general surgery. And in the pre-op anesthesia clinic, they underwent scoring using typical anesthesia pre-op scores, the American Society of Anesthesiology score, the Lee score, the Eagle score. And after adjusting for each of these, the frailty status, as assessed by the frailty phenotype in this particular study, increased or improved the ability to predict major surgical complications. So here, pre-frail adults had about 2 or so times the likelihood of having preoperative complication or postoperative complications. Frail adults about 3 times. So in addition to our current clinical measures in anesthesia, the frailty phenotype improves risk stratification, and that's informative to our surgical colleagues and informative to families. Another example of how these mobility scales can improve risk stratification is in this study that is brand new, actually, just came out this year. This is a study that described the retrospective review of the LIFE trial. The LIFE trial was a really large randomized controlled trial that tested the effects of a moderate physical activity intervention on disability versus a health education group. And so as a part of the study, they were recruited and started collecting short physical performance battery scores every 6 months. And in this particular study, they were able to identify different trajectories of short physical performance battery decline, and found that folks who had just a little bit of decline, if they were on a rather than being stable in their SPPB, if they had a little bit of a decline, that trajectory greatly increased the likelihood of early major mobility disability 6 months later, which they characterized as an inability to do a 400-meter walk test in 15 minutes. And then if they were on a even more aggressive kind of trajectory based on these repeated SPPB scores, they had nearly a 5 times chance of having impaired mobility disability 6 months later. So again, just demonstrating that the quantification of the mobility impairment using these established scales does help us communicate as geriatricians and geriatric providers to others about risk for various outcomes. And then the final sort of value that I want to bring up, again, separately, that's related to others, but I think offers a unique contribution to our evaluation, is that gait assessment in particular is strongly predictive of mortality. This was a study that was done by Dr. Studensky and published in JAMA a number of years ago now, that pooled over 34,000 older adult participants in 9 different cohort studies to relate gait speed to mortality over the course of 6 to 21 years. They had variable follow-up time. And in short, every 0.1 meter per second change in gait speed was associated with a statistically significant different mortality risk. So really granular at this level, and across all age groups that was true. And they went on to show that the gait speed assessment with age and gender were just as good as predicting remaining life and survival as a much more complicated model that used comorbidities and smoking status and BMI and various other things. So gait speed, I think, adds a lot here to survival. And for a geriatrician, thinking about roughly how much time people are going to be on this earth can help us think about an overall plan. What can we do to optimize what time they have left? So this, I think, is yet another value that a mobility assessment can add to what we're doing in clinical care. Okay, so let's talk now about when and how we conduct a mobility assessment. Do many people do mobility assessments already routinely? Maybe a wave of hands here. Some people are doing it. Yep, looks like people are good. I'm so glad to see. So you guys are kind of comfortable with this already. I'm just going to kind of highlight a couple of pearls about this and what we do and do not know. So my first thought, when I was thinking about doing mobility in our clinic was, well, when do we start it? When do we start assessing mobility in older adults? And how frequently are we supposed to do that? Well, as it turns out, we just have early guidance from the literature on this. It's not particularly well established across societies when we should be doing this and how frequently. And so I just highlighted a couple of different guidance that we have from different groups. So obviously the Age-Friendly Health Systems Guide, which you guys are very much in support of and is a great manual, suggests that mobility should be assessed and addressed at essentially every encounter at some level. And so they're kind of like, it's such a priority for older adult health. We should really be doing this all the time. Then if you go into sort of the frailty expert recommendations, they are a little bit more conservative and say, well, we should be doing a frailty screening in everyone over the age of 70 and in anyone who's had a 5% weight loss in the prior year or more. And so trying to capture the people most likely to have at least to benefit from screening and then to move forward from there. So slightly different group. And then finally, there's groups and societies that, that recommend doing a mobility assessment after a certain symptom or event trigger. So for example, the American Geriatric Society absolutely recommends doing a mobility assessment on anyone who screens positive for their fall screening questionnaire, which is a series of 3 questions. And the American Geriatric Society and American College of Surgeons absolutely recommend now a mobility assessment as part of a preoperative evaluation for older adults. So there are definitely times during our clinical care in which experts are saying we should be doing the mobility assessment, and we can select which of these we want to follow. But again, this is just early guidance. There isn't necessarily consistency across all of these recommendations. with regard to the question of frequency, I think this we know even less about. So I shared an earlier study, and I'm about to share this study that we're one of the few that have looked at the value of repeated mobility assessments to risk prediction above and beyond a single baseline assessment. So this was a study that was conducted in the Health ABC data set, in which the investigators recruited fully functional and healthy older adults into communities. And then they began collecting gait speed data in year 2 and variably throughout the rest of their follow-up time. For this particular secondary analysis, they enrolled or included participants who had at least 3 gait speed data points between year 2 and 10, so over an 8-year follow-up period. They were able to identify 3 general pathways that people follow. There were people who had sort of followed a slow decline, others who had kind of a more moderate decline, and then some who had even faster decline in their gait speed. And these trajectories actually could be differentiated in just the first 2 years of their data points. Now, this is hard to see in this figure, but they did a secondary analysis where they just looked at the first 2 years of data points, and they could actually decipher these trajectories in just a few short years. Then they were able to show that the trajectories, the multiple data points, improve prediction of mortality above and beyond the baseline data point. So at least this study, and one that I showed earlier, suggests that there is some value in repeating these assessments. How often should we do those? Not really sure. This would suggest that at least every a couple of years or every year would be valuable, especially if we're planning to plot a trajectory. But what if you have someone who's on a faster decline here? Do we need to do that more frequently? I'm not sure. Looking at some of the frailty literature, we know if you wait longer intervals, everybody gets progressively worse over time with age. But you'll see here along the aging spectrum, as you get older, you also decline faster. And so again, should our frequency be changing with increasing age? This is some unpublished data from our frailty clinic, which I'll talk about in more detail soon, but just looking at shorter periods of follow-up, just a 1-year follow-up, there's definitely movement to a worse frailty status or more impaired mobility over time, even in short durations like 1 year. But you also see some return to improved states. So this is really a dynamic change over time in function and mobility. And so we don't really know if capturing the dynamic kind of movement is also important for risk prediction, but certainly that happens. So I think some of the remaining questions that we have, the literature, that researchers and the literature need to kind of share with us and guide for us is really how frequently do we need to be doing these mobility assessments, and when do we start them? And then importantly, does the frequency need to increase as mobility impairment worsens or as people age? These are questions that we don't really have great answers to, and that we still are trying to sort out. So if anyone wants to do a study on that, it's definitely needed. Okay, now in terms of how to conduct mobility measures, so for those of you who are already doing mobility, I'm sure you will agree that standardizing how you collect the measurement is actually really important. There is significant evidence in the literature of within subject and between administrator measurement variation that can contribute to some measurement error. And so standardizing how you collect those and how you collect them among providers in particular is really important. So I'm showing here a static image of a YouTube video that was put together by the NIH for their NIH Toolbox. This is a 4-meter usual walk test that they're demonstrating here, but there are multiple others on their website, and they promote trying to align these administrative protocols among studies, but I think this is also true in clinical care. As we start to rely on these mobility assessments to help us with our planning and our care, we really have to standardize how they're administered. So I just would emphasize that, that you plan something like that for your clinical care practice. So how do we do this? So in 2011, we started a consultative clinic called the Successful Aging and Frailty Evaluation Clinic, in which we conduct a comprehensive geriatric assessment, and then we we add frailty and mobility measures within that in a standard way. So all the patients that come to us get the same exact frailty and mobility assessment. So our assessment looks a little like this. It takes an hour and a half to complete from start to finish. Again, every single patient gets this evaluation. We include, in terms of mobility, we include the frailty phenotype, which has an 8-foot usual walk, grip strength, and physical activity as part of the tool. And we also include the short physical performance battery, which has the 8-foot usual walk, the 5 repeated chair stands, and 3 static balance poses. We then score these patients on each of these different domains. So just a couple pictures of our clinic. To do this logistically, we have all of the gait assessments taped out on the floor, so we're all using the same area and space. We all have the same calibrated dynamometers that we use for the grip strength. We have all the sturdy chairs in the room to be able to do the chair stands and the balance testing and things like that. So we kind of standardize our protocol among our team members at the very beginning. We have a standardized note template, so we enter in the data for gait speed and strength, the various strength measures in a consistent way to all of our referring providers and in our note template. And then when it comes to sort of interpreting this, we just use the evidence-based scoring for all of these various assessments. And occasionally when available, we will also refer to reference data. Now, there isn't actually as much reference data for these measures, current reference data, as you'd think. There's actually quite a few different countries that have more recent reference data for some of these mobility measures, but the US is kind of lacking. So we're actually working on that now to use some of our national data sets to produce more accurate and up-to-date reference data. And I actually did look for some of the American Indian kind of groups to see if there's any reference data for them. And I didn't find any at all. And there's definitely evidence comparing these reference data across countries that there's substantial cultural and ethnic variation in the distribution of the performance of these measures. So you really have to be sort of sensitive to that as well. Okay, so I'm going to move into integrating how we sort of integrate these mobility assessments right into our management plans. So based on the literature review that I provided that sort of outlines some of these unique value added elements that mobility can bring to our assessment, we sort of have proposed that there's 3 ways we can incorporate this mobility data right into our assessment. The first one would be to directly address the impairments that we find on our exam, and I'll talk about that more in a minute. The second would be to use that quantification or the numeric value of their impairments to help augment our risk assessment prior to particular procedures. And then the third is to use that information, the mobility information, to help us frame our overall care plan, differentiating that health variability that we talked about on the very first couple of slides. Okay, so what do we know about improving mobility limitations from the literature? First, we know from now a number of trials that weakness does get better with resistance training, plus or minus a little bit of nutrition supplement. We know that is possible, and we rely heavily on our therapists to help us with this. We also know that physical activity itself, as a sort of separate measure of mobility, also improves with activity interventions. So we can address those deficits specifically. But there's some caveats that the literature brings up. For example, there may be groups that benefit more than others from these mobility interventions. So for example, in one of the LIFE trial, they found that people who were younger at enrollment and randomization, people who had more functional impairments at baseline, made more progress following the intervention. They actually improved more than others. Kind of interestingly and somewhat ironic, the people who were actually more physically active at baseline also saw more benefit from the intervention than others. So there are going to be people that that maybe don't improve as much as others, despite having a very important and evidence-based intervention. And that I think is very still difficult for us to know how to address. The second thing we know from the literature, in more recent literature, is that the intensity of the intervention might actually make a huge difference. So, for example, a colleague of mine, Dr. Danilovich, all these references are at the bottom of the slides, by the way. Dr. Danilovich had done a high-intensity walking pilot study in a very small group of assisted living residents who were frail and pre-frail. And some of them were wheelchair bound, walkers, so a very high risk group. And she had them doing complex walking tasks. They were doing dynamic kind of 4-square walking. They did some backwards walking. They were going up and down stairs, very high intensity for this group. And in 12 sessions, they all made statistically significant improvements in their strength and balance and walking. And so I think, you know, some of the negative findings in some of the trials that haven't shown significant changes in activity or weakness has been because they haven't been appropriately dosed. So intensity is really important here. I think the caution with the intensity is that there also is an increased risk of injury. And so finding the right group to do that is also important. We don't want to exacerbate COPD or anything like that. But certainly intensity is very, very important here. And then finally, you know, most of the trials that have evaluated change in mobility, change in frailty, are looking at outcomes that are directly related to their muscle function or activity. So they're measuring change in muscle strength, they're measuring change in routine activity. They are not, fewer studies, I would say, fewer studies are actually testing change in the physiology or change in the longer term outcomes. And one example of a study that did this was just published this year, the STRIDE trial. This was a study in which older adults who were at risk for falls underwent an intervention for fall prevention. This was in a randomized control trial as well. And the intervention was nursing led. They did a standard intervention. All the nursing interventionalists assessed 7 different risk factors. They had a protocol kind of driven recommendation plan when they found the risk factors. And then they additionally did an individualized plan for at least 3 of the risk factors. They implemented it, they had referrals, they followed them up, the very detailed, wonderful intervention that was done in real life practice and in conjunction with primary care doctors. And after over 40 months, I think it was 44 months of follow-up, they had absolutely no change, no difference in injurious falls or hospital-related, or falls that caused a hospitalization. And so I think this is a study that we need more of. We need to be assessing the downstream kind of clinical outcomes and testing this in a real kind of life experience. And so we, you know, it's not clear yet if physiology improves. You know, if we did some resistance training preoperatively, is that actually going to reduce our surgical mortality? You know, these kinds of studies. So there's a little bit of room to grow here. But we can definitely address in our plans, we can definitely address weakness and activity. So that's one way I think we should translate our mobility assessment into our care planning. The second is about augmenting risk. So I mentioned in our clinic, we assess multiple domains in our assessment and plan. And this is an example of the report card that we include in our note, where we can actually administer evidence-based tools. We provide a score for performance across these various domains. And this then becomes a communication tool to our referring providers. What I like about the scoring and risk assessment is we can actually highlight where people are doing really, really well, also using the scoring, as well as identify the areas that are kind of need some more support and how that translates to kind of overall risk. We use this tool to help us standardize among providers the communication, again, that we translate from our assessment. And another tool that we use with this risk assessment is specifically in our preoperative evaluations. We have a templated table where we can use the scoring for these various domains and have it translate into kind of a surgical risk assessment that we do. So among providers, we're again standardizing how we are interpreting these tools into a risk message. So I think this is a second way that the mobility assessment can be used right in our note, is giving an overall risk assessment. And then third, for us as the providers, we're staring at that 80-year-old. We don't know where on that health spectrum they are. These assessments can really help us operationalize, their overall vulnerability and frame our entire care plan based on that. So for example, if someone was frail on one of these mobility assessments or tools, we would be very targeted, reducing sedentary behavior, not doing moderate to vigorous activity. We would be liberalizing their diet. We would be maybe not doing as many cancer screenings because they wouldn't be beneficial, where in a vigorous or non-frail person we would. We would do very close, frequent visits and prioritizing comfort rather than tight control of their comorbidities. So you can see how our assessment and plan would be altered just based on their overall performance on these tests. So I think this is a third way that our mobility assessment can be translated into our care plans. Okay, and then finally, I'm going to end with a little innovation in mobility assessment. This is an area of research for me. So having done mobility assessments now 9 years in our SAFE clinic, I can tell you that it's not always easy to do. I can promote it as much as I want right now, but practically speaking, it can be difficult. I would say our biggest barriers have been the time commitment and the billing. We constantly have to fight with our administrators that it's okay to have an 1.5 hour long assessment. So we do, there's things that we do to try to help with that, but it isn't always easy. I think standardizing these measures across providers can be challenging. You guys probably deal with this even more than we do, but there's probably a number of patients that are rural dwelling or homebound where you're only administering televisits to reach them. How are we going to do mobility assessments over video? So there's lots of issues here. And then finally, one that I find I think about a lot is, if someone's coming in today and I'm doing an 8-foot walk on them, if they happen to have a bad day that day, how is that really reflecting, that single encounter actually reflecting their overall life? Do we need to have more kind of a bigger, broader assessment of them? So these are some of the challenges we face. So I became interested in accelerometry because of all of those reasons. An accelerometer is a wearable device. Many of you probably have one. There's actually an accelerometer on your phone. There's an accelerometer on your iWatch. They're just not as sensitive as the research grade devices, so they are everywhere. They continuously collect acceleration data. And most of the research studies that incorporate them, study participants will wear them from anywhere between 3 to 7 days or even longer, depending on the battery life. And what's great about them and why I was so excited about it as a geriatrician is that they are measuring mobility in the free living environment. We're actually getting real life mobility data as they're in and out of their moment to moment life. There are now a number of epidemiologic studies that include accelerometry in them. I've just included a few of them here just to show that there's a lot of interest in this. To orient you a little bit to accelerometry, I have here 1 day worth of output from a hip accelerometer, a hip-worn accelerometer. Because the device is continuously collecting data, it has to select when it's going to record a value. And depending on the settings, it can have up to 100 data points recorded on the device every second. Well, that's usually too much data for most people to analyze. And so the data from those 100 points is averaged over a particular time interval. And that time interval is called an epoch. In this case, the data are averaged over a single minute, 1 minute epoch. And then each little spike here is the translated electrical data into a unitless measure that we call a count. And that count is generally body location specific and sometimes device specific. but it does reflect overall intensity. So the higher the spike, the more intense the activity is. The lower the spike, the lower the intensity. So that's for the overall frame here. So accelerometry provides these really high resolution logs. I showed you 1 minute epochs, but this is even greater granular level of data. This is 24 hours of data at the 1 second epoch level. And you can see if you just take a little tiny 1 hour of data here and spread it out, you have even more granular data to look at and interesting patterns to find. And if you take just 1 minute of that hour and space it out, you're getting even better data in smaller segments of time. So you're really getting this kind of forest view of mobility all the way to the tree view of the mobility. Never before, we could not collect this kind of stuff in clinic. So historically, researchers would take this accelerometry data, these huge log files, and would summarize them into single measures across the entire wear that were averaged over the entire wear time. So very similar to probably what you collect on your iWatch or your phone, an accelerometer can estimate about how much time in a week you spend in sedentary behavior or about how much time you'd spend in vigorous activity. They can also sum how much activity you've gotten over a course of several days or an average over several days. They can count how many periods you had of like 30 minutes of consistent activity or 30 minutes of consistent sedentary activity, or you can just get a general average activity level over the entire wear time. So these are sort of traditional measures. And when I first started working with accelerometers, I wasn't at all convinced that they would be able to differentiate health in older adults, largely because as a population, older adults are pretty inactive. So I thought, really, how are these going to be able to differentiate, health if everyone spends 97% of the day in light activity? Well, as it turns out, when we studied some of these classic accelerometry measures, actually were really strongly related to the mobility measures that we collect in clinic, the 3-meter time gait, chair stand performance. They also reflected some of the underlying physiology, comorbidities, and even disability. So that sort of made me a little bit more supportive of the devices and thought maybe there's something here that we can use. Others have shown that these classic accelerometry measures are related to mortality, to disability, hospitalization, even readmission. So we actually have a ton of literature now supporting the use of these particular classic accelerometry measures in predicting these outcomes. Just literally thousands of papers. However, you can imagine when we summarize all of that big data into a single measure of activity, for example, you lose a lot of information. These are 4 logs of 4 different people wearing an accelerometer for 3 days, and you can see an average of their hourly activity across all of the daytime wear here. And just looking across these 4 individuals, they don't look the same. There's a lot of interesting movement here and seeing when they're active and how long they're active and which days they're not active and which they are. And there's a lot of variance here that's could be informative that we sort of lose when we summarize the data. So more recently, people have started to explore this and have included things like using a small signal, just a little tiny snippet of the activity log to pick up an acute fall using like what they call a wavelet prototype of what a fall typically looks like. There's other people who have used continuous data as a sort of a curve of movement and studied the relationships with that. And then, of course, there are plenty of people now looking at machine learning and artificial intelligence and how we can use those things to help us interpret the mobility data. So a little bit of work that we've been doing is on this level of like looking at the more granular level data. This was a study in which we got a little bit more granular. We looked at hourly levels across the day. And in this particular study, we related these hourly activity patterns across the day among frail, pre-frail, and non-frail groups. And what you can see is that frail adults indeed do have lower activity across the day, but really it's mostly differentiated in the morning. And this is in complete contrast to increasing age, where the increasing age is associated with lower activity in the afternoon. So there's something about being frail and having impaired mobility that's influencing the morning activities. So another aspect we could use to sort of differentiate health. We went on to study how consistent these frail, pre-frail, and frail adults follow those activity levels across the day at each hour. And while their sort of mean activity is quite a bit lower than the non-frail adults here in the dark bar, they actually follow very inconsistent patterns across the day among other frail groups and within their own life. And so kind of this inconsistent pattern of activity across multiple days also is an indicator of increased vulnerability, or maybe an indicator of increased vulnerability. A colleague of mine programmed a way to capture episodes of walking from free living accelerometry data using sort of a pattern of appearance of the data. So they can extract, you know, an element of walking or a period of walking as someone's in their day-to-day life, and then calculate all these gait characteristics, timing, amplitude, periodicity, stride-to-stride variability, all these wonderful, rich things about walking that we can't get in our clinical assessment. Similarly, a colleague was able to calculate these interesting measure that estimates the number of times someone has to sit to go to stand, and how many times they take a break from walking or break from activity. And that active to sedentary transition, as what she calls it, is strongly related to slower gait speed that we collect in clinic, perceived fatigability, worse short physical performance battery scores, and longer 400-meter walk time. So lots of relationship here just from the mobility measures that we can get and actually really directly reflect what we could capture in clinic. This is an example of someone from our team who put an accelerometer right on their thigh and then did a 3-meter walk and a 5-meter chair stand. So you can see, you know, if you can imagine someone, you know, having a sensor on at home and being able to direct them to do a brief walk in their living room or a chair stand, you can actually capture how long it takes them to do that, and even some of their gait characteristics directly from the output from the device. So I think there's a lot of interesting ways in which accelerometry may be able to improve how we measure mobility in the future. We obviously have a long ways to go to translate this kind of information. Which of these measures is the most valuable? Does it improve in any way our risk prediction above what we can cheaply do in clinic? And do these measures correlate? We don't really know. So there's a lot of work to be done, but it certainly is an area that I think we'll see some more growth in particularly for older adult mobility assessment. So just in sum, and leaving some time for questions here, I want you to take home a couple of these points. One is mobility is an incredibly important measure of older adult health. It adds value in a lot of ways to our clinical assessment. There are plenty of evidence-based tools out there and combination tools. It's just really important to standardize how we collect those data. And I think hopefully I've shown you a couple ways today to take that mobility assessment data and actually translate that into some sort of plan and change the way that we care for older adults. And I think accelerometry offers a really interesting and potentially innovative future way to assess mobility in the free living environment. But there's a lot of research left to be done. So hopefully I will continue to chip away at that, but I do think kind of stay tuned for what's in store moving forward. So I will stop there and see if there's any questions.